Good day to all our beloved lecturers. We are from Group 4 Team A, going to present the surgery and infectious disease case.
So this is a case of a 70 years old female patient came with she complains of having harsh productive cough, with sputum appeared to be yellow and streaks of blood for about 4 days prior to being seen by a physician. She had pain in her right chest that intensifies with inspiration. She is underweight and had lost 5 kg for the past few months, with no loss of appetite. Other medical conditions are such as diabetes mellitus, hypertension, heart failure. She went for PPM clinic a week ago, and her past medical history is that she had mild asthma since childhood. She is currently taking metoprolol, amlodipine furosemide, metformin, salbutamol, and also budesonide. She has also allergy towards celecoxib and also cloxacillin. For diagnosis, patient might have community-acquired pneumonia, which can occur outside of the hospital or healthcare facilities. This can be explained through several supporting evidence, such as the risk factors, including the age, which is more than 65 years old, exposure to pollutants, underweight, as well as having several medical conditions such as asthma, diabetes mellitus, and also heart failure. For signs and symptoms, patient experienced fever, chills, productive cough with yellow sputum, and also chest pain. Her white blood cell and also lymphocytes level were elevated, showing sign of infection. Based on physical examination, late inspiratory crackles are heard, which can be presented in patient having pneumonia. It was then confirmed through chest X-ray that she had acute pneumonia in the right middle lobe, and atypical cells were observed through sputum cytology.
For management, we suggest patient to be admitted. CRB 65 score of 2 and above and pneumonia severity index score of 3 and above suggest patient to be hospitalized. However, this prediction too suggests supporting evidence. Recommended treatment for patient may prolong QT, and patient was diagnosed with heart failure, so ECG should be monitored closely. Also, patient presented with sputum with streak of blood should be monitored closely. For CAP, the goal of treatment is to eradicate causative pathogens, resolve clinical signs and symptoms, minimize hospitalization, and also prevent reinfection. Recommended treatment for this patient is ceftriaxone 2 grams for 5 to 7 days IV and azithromycin 500 mg IV for 3 to 5 days. Administration of IV antibiotics for patients hospitalized for CAP at the start of therapy is favorable because of the high mortality associated with CAP. The recommended treatment is further supported by BPUKM anti-infective guideline. Also, in comparison with beta-lactam monotherapy, beta-lactam macrolide dual therapy might reduce the mortality risk in patients with CAP. The combination therapy has better coverage of atypical microorganisms, and they act at 2 different sites in the bacteria.
Considering patients are penicillin allergic patients, the use of third-generation cephalosporin, which is ceftriaxone, seems to be safe as the estimated cross-reactivity is low, which is 0.7%. However, we need to further evaluate the penicillin allergic severity. Both monotherapy of oral levofloxacin or combination therapy of ceftriaxone plus azithromycin are effective to be used in patients with CAP who require hospitalization. Azithromycin may be less likely to cause QT prolongation and cardiac arrhythmias in the macrolides. One of the significant adverse effects of levofloxacin is seizure. Noted that the patient have the risk factors that predispose to seizures such as diabetes mellitus, elderly, and renal impairment. Thus, the use of levofloxacin for the patients needs special precautions. There is also possible interactions of levofloxacin with the medication prescribed for the patient. For the durations of antibiotic therapy, it is guidance to the clinical stability achieved by the patients and with the minimum of 5 days of therapy. Although the patient can achieve the clinical stability within first 48 to 72 hours, a total duration of therapy of 5 days will be appropriate. To switch IV administration to oral administration, few criteria that needs to be met, such as temperature less or equals 37.8 degree, heart rate less or equals 100 beats per minute, respiratory rate less or equals 24 breaths per minute, systolic blood pressure more or equal 90 mm mercury, oxygen saturation more than 90%. We suggest to switch IV ceftriaxone 2 grams to oral cefuroxime 500 mg BD and IV azithromycin 500 mg to oral azithromycin 500 mg.
For drug-related problems, firstly, patient was prescribed with tablet augmentin. Augmentin contains amoxicillin, which is a type of penicillin. This should be avoided in patients with penicillin allergy. So alternative of ceftriaxone plus azithromycin should be given instead, and test dose challenge should be performed prior to use. Next, azithromycin may cause increased CV events. Patients has hypertension and heart failure, which is a concern of use of azithromycin might increase risk of mortality and CV events. However, in this patient, its net benefits of use in older population is greater than its risk for pneumonia. Next, the use of CCB in heart failure patients may be an actual problem. The routine use of CCB in heart failure patients is not recommended due to worsening HF outcomes, and also it seems not to improve clinical outcomes in general. Third intervention would be to suggest change from CCB to ACE inhibitor, which helps improve survival and quality of life in all classes of HF. And this patient must be initiated with low-dose ACE inhibitor cautiously.
Pharmacist intervention can be done by switch therapy after clinical condition improves and de-escalation therapy based on CNS results. Next, patient education on inhaler technique, medication adherence, and target for controlled BP and glucose level are important. Next, non-pharmacological advice involving healthy diet and reduction of sodium intake. And lastly, medication reconciliation and review to identify and prevent possible drug-related problems on patient's medication.
For monitoring parameter in terms of efficacy, blood CNS results should be taken to identify the type of microorganism. Next, monitor the sign of infection, which is represented by the high temperature and high WBC level. Lastly, is the chest X-ray follow-up to have a radiographic image of the lung. Moving on to the monitoring of safety parameter, renal profile and hepatic profile should be monitored prior to the use of antibiotic. Next, monitor the hypersensitivity reaction, especially due to the usage of ceftriaxone. As the patient are allergic to penicillin, cross-reactivity between penicillin and cephalosporin might be occur. Moving on, monitoring of ECG is required as azithromycin is associated with QT prolongation. Lastly, is monitor for any asthmatic side effect, as myasthenia gravis is one of the significant adverse reactions of azithromycin. That's all from us. Thank you.